Hi, I'm Dr. Jeff Cohen. I'll be lecturing on lower limb orthotics and prosthetics. I'm a clinical professor of rehabilitation medicine and medical director of the Medically Complex Rehabilitation Program at Rusk. What is an orthosis? It's an external device that is used to selectively apply force to an extremity. It can support or realign one or more body segments. It can improve function by controlling motion or prevent progression or correction of a deformity. An orthosis can also reduce axial load or weight bearing on a portion of an extremity. It can help to reduce muscle tone, and it can provide proprioceptive feedback. Orthoses work by utilizing a three-point pressure principle. A single force is placed at the area of deformity or angulation, and two additional counterforces act in the opposing direction. This three-point force system can reduce unwanted angular rotation and can also result in stabilization about a joint, bone, or skeletal segment. An AFO is known as an ankle-foot orthosis. It can be utilized when there is weakness of the dorsiflexors of the foot and ankle and help prevent foot drop. It also can be utilized if there is weakness of the ankle plantar flexors and can assist in push-off phase. It can help to control ankle instability and can be utilized to help with pressure relief from sensitive areas. AFOs can be made of a combination of metal and leather, thermoplastic materials, thermosetting plastic, or non-custom made, that is, off-the-shelf materials. AFOs that are made of a metal construction are heavier and more durable. However, they are less cosmetic and they have less contact with the skin. They are indicated in cases where there is fluctuating edema of the extremity. AFOs that are made of plastic construction are lighter and less durable than metal AFOs. However, they are more cosmetic and have a more intimate contact with the skin. They are less appropriate when there are volume changes in the extremity and less appropriate if the foot is insensate. This slide indicates the common ankle-foot orthoses, going from the posterior leaf spring orthoses or the PLSO to the solid ankle orthoses, then articulated ankle-foot orthoses, then the floor reaction orthoses, and then the patella tendon bearing orthoses. The posterior leaf spring orthosis, or PLSO, is most utilized when one has a pure foot drop. Its primary function is to control plantar flexion at heel strike and to maintain dorsiflexion during the swing phase. It has narrow trim lines which just encompass the Achilles tendon. It provides very little medial lateral support. PLSOs can be made of carbon fiber material, as is demonstrated in this slide. The carbon fiber design provides excellent strength-to-weight ratio and dynamic motion. It also controls plantar flexion at initial contact and helps to prevent foot drag and foot slap during the gait cycle. It reduces energy consumption by reducing hip height. When one requires more medial lateral stability of the foot and ankle, one can utilize a semi-solid AFO. The trim lines come more anterior and bisect the malleoli. With the more medial lateral stability, there is more contact with the patient. The disadvantage is there is less flexibility, as this brace allows less motion from heel strike to toe off. When one requires more medial lateral stability, one can utilize a solid AFO. This is particularly helpful in conditions where there is a flail foot or a spastic foot. Compared with a semi-solid AFO, the trim lines come even more anteriorly and actually encompass the malleoli. The disadvantage is that this brace allows less motion from heel strike to toe off than even the semi-solid AFO. Another AFO option when one requires medial and lateral stability of the ankle is an articulated or hinged AFO. This brace can control endpoint of dorsiflexion and plantar flexion range. It can provide a dorsiflexion assist or a plantar flexion assist as needed, or it can provide a dorsiflexion stop or a plantar flexion stop. The range of motion can be set to allow only a certain degree if needed. In cases where the quadriceps are weak and there's a tendency for knee buckling, one can utilize an anterior floor reaction orthosis. This is a solid AFO with an added anterior piece directly connected or a separate shell strapped on. It provides significant knee extension moment force during the stance phase. Contraindications to utilizing an anterior floor reaction orthoses are knee hyperextension, an unstable knee, or the presence of a knee flexion contracture exceeding 15 degrees. A PTB orthosis, or a patella tendon bearing orthosis, can be utilized to unload the hind foot. It can be made of an all-plastic or plastic metal construction. Proximally, it has a PTB shell for patella tendon weight bearing. Knee orthoses can be utilized to provide medial lateral and/or anterior posterior and/or rotational control. They can be prefabricated or custom made. They can be rigid with no knee joints, or they can be articulated with a knee joint. A Swedish knee cage is a knee orthosis which is useful in controlling mild cases of genu recurvatum. It utilizes a 3-point pressure system in which there is an anteriorly directed force in the popliteal crease and posteriorly directed forces both above and below the patella. Functional knee orthoses can be utilized to limit anterior-posterior, medial lateral, and/or rotational movement. They can be custom made or custom fitted and used post-surgically after anterior or posterior cruciate ligament repair. Knee ankle foot orthoses, or KAFOs, are used for cases of severe knee instability. They extend proximally to the knee joint to within 1.5 inches of the perineum. The distal portion of the brace is an AFO. And in addition to that, it has knee and thigh sections added. The brace can be made of all metal or plastic and metal. There are several types of knee joints, ranging from single axis to offset knee joint to adjustable knee joints to a polycentric knee joint. The single axis knee joint is the most common. It has one point of rotation, it is lighter in weight, and tends to be inexpensive. An offset knee joint is utilized when one needs increased knee stability. The knee axis is posterior to the metal upright. This knee joint tends to be bulkier, heavier, and more expensive. When one aims to correct a flexion contracture of a joint, an adjustable range of motion knee joint is valuable. It has a dial mechanism which allows one to adjust the range of motion in the joint. These joints, though, tend to be bulky and more expensive. A polycentric knee joint has a tooth gear mechanism utilized to simulate an anatomical knee joint. However, the disadvantage with this knee joint is it tends to be bulky and prone to wearing down of the gears. Two commonly used locks on these knee braces are drop locks and bail locks. Drop locks are rectangular pieces that drop over the knee joint to stop flexion. They are easy to use, lightweight, and inexpensive. Bail or Swiss locks are good for individuals who have bilateral knee instability and for patients that cannot manage the drop lock mechanism. These locks are spring-loaded, they lock on complete extension, and they have a posterior handle that lifts up to unlock. They can be very bulky, heavy, and expensive. There are several KAFO braces that I would like to discuss. These are the stance control KAFOs, the ischial weight-bearing KAFOs, Craig-Scott orthoses, and also the HKAFO, or hip, knee, ankle, foot orthoses. When one ambulates with a traditional KAFO, the knee is locked in full extension, which provides stability but also creates an unnatural gait. The use of a stance control orthosis, or an SCO, allows the knee to bend during the swing phase of the gait and blocks full knee extension for stability during the stance phase. This allows the knee to bend naturally during swing phase, yet prevents buckling of the knee during the stance phase. An ischial weight-bearing KAFO is used when one wants to unload the leg and allow limited weight bearing to the hind foot. In this brace, an ischial brim is added to the KAFO, and the weight bearing is on the ischial tuberosity and the gluteal muscles. Craig Scott KAFOs can be utilized by some paraplegic patients to allow them to stand without bracing of the hip joint. In this braces, the patient locks the hips by hip hyperextension. It utilizes offset knee joints that bring the weight anterior to the knee, providing an extension force on the knee. HKAFOs, or hip, knee, ankle, foot orthoses, are needed when additional control of the hip or trunk is required, when hip extensors and or the hip abductors/adductors are of poor muscle strength. They utilize a KAFO with an additional hip joint and pelvic band or a thoracic extension. The next topic I will be discussing is lower limb prosthetics. Classify amputations through the bones of the foot as a partial foot amputation. Amputations through a joint can be classified as an ankle disarticulation, a knee disarticulation, or a hip disarticulation. Amputations involving the long bones of the leg below the knee is classified as a transtibial amputation, and an amputation through the femur is described as a transfemoral amputation. An amputation through the bones of the foot is not an ideal level of amputation. You lose the anterior lever arm of the foot, and it results in a tendency for a fixed equinus or plantar flexion contracture. There are limited prosthetic solutions for partial foot amputations. Levels of partial foot amputation include a ray amputation, which is an amputation of a toe, transmetatarsal amputation, a tarsal metatarsal amputation, also known as a Lisfranc amputation, and a mid-tarsal amputation, also known as a show parts amputation. And you can see these levels in the diagram on your right. Orthotic/prosthetic options for partial foot amputations can include custom molded shoes, a rigid foot plate with arch support that's combined with a rocker bottom shoe sole, a modified ankle foot orthosis with a toe filler, or an actual foot prosthesis, which is a custom molded socket attached to a semi-rigid foot plate with a toe filler. When describing the componentry of a prosthesis, as you can see in the next slide, on your left you see a transtibial prosthesis or a below-the-knee prosthesis. We describe the componentry as a socket, a liner, a pylon, and a foot. On your right, you see the componentry of an above-the-knee prosthesis. Here, the componentry includes a socket, a rotation adapter, a knee, a pylon, a foot. When describing the dynamics of a socket, we like to use the term total contact, in which we try to distribute forces evenly over the largest surface area possible to provide increased proprioception and minimization of distal edema. This will allow the patient to ambulate in a more comfortable manner. In describing the biomechanics of a transtibial or below-the-knee socket, we look to maximize the weight-bearing capacity of the residual limb, utilize total contact, but also make sure that we put pressure over areas that are pressure tolerant and avoid pressure over pressure sensitive areas. Pressure tolerant areas include the patella ligament, the medial tibial flare, the shaft of the fibula, the posterior musculature, such as the gastrocnemius, and the popliteal fossa. And you can see this in the diagram on your left. Pressure-sensitive areas where you want to avoid pressure include bony prominences and superficial nerves. Here, for example, you want to avoid pressure over the patella, over the tibial tubercle, over the crest of the tibia, over the fibula head to avoid compression of the perineal nerve, as well as over the distal fibula and tibia. Describing the componentry of a prosthesis, not only do we describe the socket, but we describe the suspension system, or the mechanism of how the socket is suspended on the residual limb. We utilize 3 different types of suspension systems for below-the-knee or transtibial amputations. One is called a silicone suction suspension, One is suction suspension, and one is a modified suction suspension called a vacuum-assisted suction suspension, or VASS. A commonly used suspension system is known as the silicone suction suspension, or the 3S system. It utilizes a gel liner, which the individual dons on the residual limb, which has a pin on the distal end. This pin is then inserted into a receptacle at the distal end of the socket. This type of suspension is often the one that we will use on initial amputees and may be the final suspension system for elderly and frail patients. Another commonly used type of suspension mechanism is called suction suspension. Here the individual will don the liner and then push the liner into the socket receptacle. In doing so, air is forced out of a one-way valve. The individual then caps that valve and a suction or vacuum type of system is created. Transtibial suction suspension is a secure suspension. And a major advantage is that it reduces pistoning compared to the silicone suction suspension mechanism, or the 3S system. Pistoning is sliding of the prosthesis on the skin, which is a primary cause of skin breakdown. The disadvantage of the suction suspension is that the limb must be volumetrically stable. If the wearer gains weight, he or she will not be able to get into the prosthesis. If the wearer loses weight, you can lose suction and the prosthesis will no longer stay on. A vacuum-assisted suction suspension, or VASS, utilizes an electronic or mechanical pump that removes air between the inner socket wall and the liner. It creates an active seal and minimizes motion within the socket. Advantages of the vacuum-assisted suction suspension include improved volume control of the residual limb, a reduction of shear forces within the socket, and a feeling of enhanced suspension and proprioception for the wearer. The disadvantages include an increased weight of the prosthesis and an increased expense. Suspension of the transfemoral socket on the limb is utilized via a primary suspension, which is the 3S suspension or the suction suspension. There are times when additional auxiliary suspension is required. In this case, we will use a Silesian bandage or a hip joint and pelvic band. The most commonly used type of socket for a transfemoral or above-the-knee amputee is an ischial containment design. The ischial tuberosity lies within the socket and the medial aspect of the pubic ramus is contained. It has an oval shape. It is narrower medial-laterally and wider anterior-posteriorly. It provides total contact to the limb. And major advantage is that it reduces the extent of pinching in the groin region, which had previously been noted in the formerly used quadrilateral type socket. The most commonly utilized suspension system for an initial transfemoral amputee is the 3S system, known as a Lanyard or KISS, Keep It Simple system. It utilizes a cord or strap attached to the bottom of a liner which the individual dons on the residual limb. This cord or strap is then fed through an opening in the bottom of the socket and then fixes securely to the outside of the socket. As was noted previously with the transtibial prostheses, suction suspension is the ideal type of suspension. It provides a very secure suspension and reduces pistoning. The disadvantage, as noted previously, is that the limb must be volumetrically stable. Advantages of this type of suspension include that it is inexpensive and does provide a very secure suspension. In addition, the prosthesis can be donned while sitting. Disadvantages is that it requires dexterity and strength to use, and it is less cosmetic. There are cases in which the primary suspension is not enough. In this case, we will utilize auxiliary suspension. One of the mechanisms that we use is a Silesian belt. This provides additional rotational control and security. The disadvantage is that it tends to be bulky and requires frequent replacement. Another option for auxiliary suspension is a hip joint and pelvic band. This is particularly useful for those amputees who have short residual limbs, weak hip abductors, or those who work in positions such as construction, where a secure control is required. Advantages of the hip joint pelvic band are good medial lateral stability and good rotational control. The disadvantage is that it's heavy, uncosmetic, and requires frequent maintenance. There are many types of knee components that can be utilized with an above-the-knee prosthesis. I will be discussing the single-axis constant friction knee, the weight-activated friction knee, the hydraulic knee, and the microprocessor controlled knee. The manual locking knee is a good knee for those who are at a low functional level and require enhanced stability. The knee locks at full extension of the knee. It provides maximal stability and is inexpensive. The disadvantage is that it provides an unnatural looking gait. The weight-activated stance control or safety knee is another option for those who require enhanced stability. It allows full, free motion of the knee during the swing phase of the gait cycle, but during the stance phase, it will lock at a preset angle. It will therefore prevent buckling of the knee during the stance phase of the gait cycle. Disadvantage is that it requires enhanced maintenance and can be noisy. Fluid control or hydraulic knee is a good knee for those who have increased functional capabilities. It will allow for a variable cadence. It can provide swing phase and stance control. The disadvantage is that it is heavier and requires more maintenance. The microprocessor control knee is really the state-of-the-art knee for those who have the capability to ambulate with a variable cadence. It has motion sensors that detect the knee position and can autocorrect throughout 50,000 times per second. It adjusts the cadence of the knee based on the speed of the gait and the position of the knee from readings of multiple ground reaction force monitors. Within the knee itself, there can be a hydraulic system or a magnetically charged fluid. This is also known as a computerized knee. Three categories of prosthetic feet are the SACH foot, also known as the solid ankle cushioned heel foot, the dynamic response or energy storing foot, and the microprocessor controlled foot. This figure is a diagram of a solid ankle cushioned heel foot. The SACH foot is a good foot for an amputee requiring maximal stability. It has a heel wedge that compresses to simulate plantar flexion. It has a wooden or metal keel. It is not indicated for active patients who have a variable cadence and have the capability of ambulating on unlevel surfaces or negotiating stairs. The dynamic response or energy storing foot is an excellent foot for amputees who have the capability of increased functional mobility, especially those who can walk with a variable cadence. In the dynamic response or energy storing feet, there is again an initial heel wedge compression. However, there is a return of energy at mid-stance through push-off. This allows for a smoother gait and less energy expenditure during the gait cycle. There are also microprocessor-controlled ankle-foot systems, or motorized ankles. These provide a powered push-off when the propeller ambulates forward. It also allows the foot to remain in dorsiflexion in swing phase to facilitate clearance. Disadvantages are that this foot and ankle system is heavy and expensive. Thank you for your attention to this lecture.